Very good morning. So by this time all you will know that PPH is the commonest cause of maternal mortality in our country. If we go by definition, then 300 ml blood loss with a warning sign becomes a PPH. So you become alert that time. Otherwise 500 ml bleeding in vaginal bleeding and 1000 for cesarean section. But remember one thing, if any woman becomes hemodynamically unstable, that means postpartum hemorrhage and you have to act accordingly. So PPH is the biggest and the fastest killer. It can kill a woman in 30 minutes if left untreated. Because the uterine blood flow is 700 to 800 ml per minute. So patient can die in 10 minutes. So just a brief revision of the commonest causes of postpartum hemorrhage. These are 4 T's. Atonicity constitutes to 70%. Trauma like lacerations, hematoma, inversion, rupture constitute another 20%. And if a retained tissue is there, then 10% causes they contribute to, and coagulopathy is a very rare cause, only to 1%. These are the words of wisdom by a famous obstetrician, Sir I.L. Donald, sir. He was a famous ultrasonologist also. While managing postpartum hemorrhage, the time lapsed should not be counted in a minute. One has not lost 1 minute, but 60 seconds, and each and every second is important in managing PPH. Now, prevention is always better than cure. For prevention of postpartum hemorrhage, there is a universal guideline which is called AMTSL, Active Management of Third Stage of Labor. You give injection oxytocin, 10 international units, intravascular or intramuscular, after every birth, whether vaginal or abdominal, and within the time is very important. It has to be given within 1 minute of delivery. And why it is so important? Because if you give this injection within 1 minute of delivery, then it will already prevent postpartum hemorrhage by 50%. So once you have diagnosed postpartum hemorrhage, then 4 things all start simultaneously: resuscitation, monitoring, investigation, and treatment. So whenever there is a major obstetric hemorrhage, then first you call for help, you alert everyone, call your senior nurse or senior midwife, obstetrician, anesthetist, alert your hematologist, alert your blood transfusion lab, and you please call consultant on call. It cannot be taken lightly. And the resuscitation starts with ABC, airway, breathing, circulation, and give oxygen at 15 liters per minute. Now the most important thing is fluid balance. We usually are reluctant to give fluid to them because we think that if we give fluid fast, then patient will go into pulmonary edema. Remember it is an obstetric hemorrhage, it is a severe hemorrhage. So you rush fluids. So you have to give 2 liters of fluid. 1 bottle of RL is around 540 ml. So you give at least 3 to 4 bottles and rush it in 15 to 20 minutes. And at least initially you give 2 liters of fluids, then you can give colloids. But try to give blood as early as possible and try to avoid colloids. And if no matched blood group is available, then you can give O negative blood also, and you should ask for FFP and platelets. We do not have cryoprecipitate in our hospital, but we have managed all cases of postpartum hemorrhage without this. But if it is available, it is useful. And sometimes in a hurry, we used to forget to keep patient warm. So please cover the patient and keep the patient warm and give fluids also warm. Now, as I have talked that we have to give fluid very fast, then how it is to be given? Gray cannula is the best cannula because it is 16 gauge, and you can see here that the flow rate is 180 ml per minute. I have never seen orange cannula in my life, and this gray cannula should be there in every maternity OT and every labor room. Next. So now what to do? The first 20 minutes are for medical management. You rub up the uterus, empty bladder, that is very important, and then you give injection oxytocin. Injection oxytocin is the drug for prophylaxis, drug of choice for prophylaxis, and also drug of choice for treatment. You mix 40 units of oxytocin in 500 ml and give at 40 to 60 drops per minute. And if the patient is not responding to oxytocin, then you can give methazine. If the patient is not responding to methazine, then you can move to carboprost. And if the patient is not responding to carboprost, you can give misoprostol. Remember one thing, that we give misoprostol only when the patient has not been given it as a prophylaxis. Only then it will work. Now, the maximum dose of methazine is 5 and maximum dose of carboprost is 8. and they are to be repeated at every 15 minutes. But if the patient is, here is the problem, that we keep giving them and we waste time. If the patient is not responding in 1 to 2 injections of methadone or carboprose, then we have to move up to the next uterotonic. That is the most important point. And tranexamic acid is to be given to every patient, irrespective of the type of delivery, irrespective of the type of postpartum hemorrhage, whether it is atonic or traumatic. And then you have to put 2 14-gauge cannulas or 16-gauge cannula, take blood for complete blood count, coagulation profile, liver function test, arrange for FFP, PRBCs and platelets, and you monitor the patient, maintain PT or BP lines, and consider central lines. And you always do a quantitative assessment of the blood loss and make a chart for recording. So this is a chart about the details of all uterotonics. Oxytocin, we do not give more than 3 liters, and we never give it as intravenous bolus. Ergometrin, there is a change from WHO 2025 FIGO guideline. Previously it was said that ergometrin can be used for prophylaxis, but remember it, now it has been removed as a drug for prophylaxis of postpartum hemorrhage. It can only be given as a treatment, and the maximum doses allowed is 5, and carboprose maximum dose is 8. We never give it intravascular, it is to be given intramuscular, and it is contraindicated in asthma. And misoprostol can only be given if the patient has not received it as a prophylaxis, and tranexamic acid is to be given to every patient of postpartum hemorrhage. The dose is 1 gram, to be given over 10 minutes. So this is about medical management. Now the patient is still hemodynamically stable and her PPH has not been controlled. What to do next? Next is you can put a uterine balloon. Uterine balloon can be put in a labor room also and in OT also. And if the patient is not responding to uterine balloon, you have to rule out the traumatic causes, and if the patient is not responding to uterine balloon, then you take the patient to maternity OT and you open the abdomen to apply brace sutures. But the patient is hemodynamically stable. And if brace sutures do not function, then you can use interventional radiology if it is available, or you can go for stable-wise revascularization, including bilateral internal iliac artery ligation. And hysterectomy is the last resort. And these patients usually require a SG or ICU admission. This words in red, if step 1 fails, escalate to the next step. Don't keep waiting, don't waste time. So these are the different types of balloon: condom balloon, Bakri balloon. And in the center, the Bharat balloon, which has been designed by me. It is made of medical grade silicone, 500 ml, ETO sterilized, and it is compatible both with the syringe and the IV drip set. Next. So, billing sutures. There are 100 types of sutures described in literature. Our human brain is small, we cannot remember all the sutures, so please remember 2 or 3. So what I think that these 3 are the best sutures: Billing suture, Heman suture, and Cho suture. They are very useful. And please keep a laminated diagram of these sutures in your maternity OT, so you will never forget it. Next. And next is a picture of stepwise devascularization. You do uterine artery ligation, proximal and distal, and then the anastomosis of uterine and ovarian artery near the corner of the uterus, that you can also ligate. And if the bleeding is not controlled with that, then you can do ligation of the anterior division of internal iliac. But again, next, remember one thing, our patient is still hemodynamically stable. So remember, conservative methods are used only when the woman is hemodynamically stable. Till now, whatever I discussed were all conservative methods. So your patient has to be hemodynamically stable. Next. So when the patient becomes hemodynamically unstable, then comes the role of radical surgery, subtotal hysterectomy or total hysterectomy as per the situation and circumstances. So friends, remember that we should resort to hysterectomy sooner rather than later, and you have to perform it rapidly. 3-4 clamp फटाफट लगाइए और यूट्रस को 5 से 7 मिनट में निकाल दीजिए. There is no use of saving the uterus and losing the mother. This line is very important. Sometimes in order to save the uterus, we'll actually lose the mother. So use all modalities of management of postpartum hemorrhage in 60 minutes. First 20 medical, next 20 uterine preserving surgeries, and next 20 surgical methods. And take a decision of hysterectomy by within 60 minutes, not later than that. Coming to the transfusion protocol, many types of protocols are described. If minimum basic you want to remember, you remember 6:4:4 PRBC FFP platelets or 4:4:4. मैंने सुना है बहुत लोग कहते हैं 1:1:1. अरे we will keep remembering 1:1:1 and we will give only 1:1:1. So you remember it as 6:4:4 or 4:4:4. चार तो देना है ना आपको. Our target hemoglobin is 8 gram and target platelet count is more than 50,000. My talk will not finish without mentioning these three. Temporarizing methods until appropriate care is available. Bimanual uterine compression, everybody should know. Aortic compression, direct aortic compression, it will behave as a temporary internal iliac artery ligation. And last but not the least, non-pneumatic anti-shock garment. इसकी आज training भी होगी. Every maternity OT, every referral center like CSC, PSC, and every ambulance should have this NASG garment. I have given it a new name. It is a life-saving garment. And in Tamil Nadu, every ambulance has this NASG. This is a documentation chart. I will share it with everyone. Cannot read whole because time is limited. It serves as a checklist. आपको क्या क्या काम करना है और वो आपको डॉक्यूमेंट करना है एंड इट गाइड्स यू व्हाट नेक्स्ट व्हाट नेक्स्ट व्हाट नेक्स्ट सो दिस इज वेरी इंपॉर्टेंट जस्ट हैव अ लुक आई विल शेयर इट विद एवरीवन सो थैंक यू सो मच zero maternal mortality from PPH is available and this should be our imperative goal. Saving mothers saves families and we are here to save families. Thank you.